Hey you guys, Mr. Forney here, coming in. I know it's another snow day, which is a little funny, but what can you do? We got a ton of snow over here. But I don't want you guys to miss out on any lecture. So this is an important lecture. We're going over physical assessment, and that's where our whole thing starts. You remember our ADPI, assessment, diagnosis, planning, interventions, and evaluation. So our first step is assessment. So our whole day starts with assessment. It is the foundation of your excellent nursing care. You'll use it every single shift you show up. Depending on where you're working, probably pull out big pieces of it throughout the shift too. So we start strong and we'll get somewhere. You guys can do it. We have some learning outcomes that we'll address. This includes data collection, plan of care, informatics. So this is all aligned with our overall course, our program curriculum. We have 3 levels of physical assessment. There is a comprehensive health assessment. This assessment covers everything. We're just head to toe, and then everywhere they came from too. So this is including your hands-on skills that you're learning in Skills Lab, but it's also including what brought them to the hospital. What is their lifestyle like at home? What medications are they taking? What other comorbidities do they have? This is usually done when they first come into the hospital to make sure we have a real foundation to start with. We also have a focused assessment. This is a specific body system. So if you did, for example, you did your comprehensive assessment, then an hour later you notice they're breathing a little funny, you're going to focus in just on the respiratory assessment there and listen to their lungs and pay more attention to that specific body part. So we get a little more detailed on one thing, and I'm not so worried about your foot that maybe you stubbed your toe a week ago, but I am worried about the symptoms that you're showing right now. Likewise, if you're in a dermatology clinic or something, you're going to focus your assessment on the integumentary system, the skin. And then we have an initial head-to-toe shift assessment. So every time you show up for a shift in the hospital, you're doing a head-to-toe assessment. This is the most like what we're practicing in Skills Lab, where it's a quick look at all of the systems to make sure we know where we are and we have a baseline to go from. When do we perform these head-to-toe assessments? So admission to the unit. If they have transferred from another unit, you're doing an assessment. When you have a new shift, when you come on to change from another nurse, you guys do handoff report, and then early in the next shift, you need to do your comprehensive head-to-toe assessment. If the patient's condition changes, why do you need to be in acute care, on an acute care floor, like a telemetry floor or med surg or whatever? Because you could acutely change. So if the patient's condition changes, you need to do an assessment. We also need to follow up and do assessments to see if our nursing care is getting anything done that we want to get done. So did our plan work? When we measure our evaluation, this is how we do that. And then if things just don't feel right, trust your nursing judgment and do an assessment so you can actually dial in on what exactly may be wrong. That's how we figure this stuff out. There are 6 main assessment techniques we're going to talk about. The interviewing is just talking to your patient. This is probably your best way to get the most information. What's normal for them, what their concerns are, what do they bring to the table. They know themselves better than you're ever going to know them. So use that. Don't be afraid to talk to them at any point throughout your assessment. And in fact, that's the best way to get your assessment. I mean, how else are you going to know the last time they went to the bathroom? You know, if they're confused and can't communicate, then yeah, you have to go back to the record and see what the last nurse aide said or whoever. But if they are oriented, they'll say, oh yeah, I went this morning, and they probably didn't even call you, so it's all good. Palpation, that's touching. So we can feel things. We can feel the temperature of skin and how soft or firm it is. We can feel around the abdomen to check for any of that kind of stuff. Does it feel tender? We feel for our lymph nodes. We feel pulses. We do a lot of feeling. Auscultation. You all know what auscultation is now. That's listening. So that's using my stethoscope specifically because I don't want to put my ear directly up to my patient. And I can hear a lot with that. I can hear breath sounds in all the lobes of the lungs. I can hear heart sounds. I can hear bowel sounds. I can even listen, once we get into, this is a little later, like a AV fistula they use for dialysis. You need to be able to hear a thrush or a bruit with that. Very interesting. Then we have inspection. That's what we see with our eyes. We can tell color. Skin color, is it bright, is it dark, is it mottled? We can tell if something, if a wound is puffy. All these things you take in with your eyes that you take for granted at first, now we're actually assigning value to. These things mean something. We can tell if fluid that's draining from someone is clear or it's bloody or it's purulent. And you can tell even like a pupil assessment. The eyes, you're looking at all kinds of stuff. Percussion, as LPNs, we don't do as much, and even as RNs, I don't really percuss, but that's that thing where you tap around the bowels you might see a video of. Don't stress that as much at this point. And then olfaction, what's that? What does it smell like? I'm still a little stuffy from last week, so my smell is not as good as it has been, but we can tell a lot with smelling too. Does someone have a weird odor or a sweet odor sometimes, an acetone odor? That can be a sign that kind of sweet acetone smell can be a sign that someone's in diabetic ketoacidosis and they're breathing out all those acetones from this weird metabolism. So interviewing, this is talking with your patient. You're asking questions. They're pointed questions. I don't need to know every piece of their life history, but I want them to feel like they're at the table. So I will encourage a little bit of extra communication, but I really want to focus and point it back in on the task at hand. This is something that comes with practice because some people want to talk and talk and talk, and some people won't want to talk at all. But at a minimum, we want to find out their chief complaint. That's what brought them into the hospital. So, ow, I stubbed my toe. That's their chief complaint. We want to know how long that's been going on. If you're in for breathing difficulty, when did you start having breathing difficulty? Ask them that. What other past medical history have you had? Oh, I've got COPD and I've got heart failure and I take Lasix every day, all kinds of stuff. Medications, we want to know what they're taking, how often they're taking it at home, because it will probably not match what's in the medical record. I know I've had a number of doctor's appointments recently, and despite trying to update my medications every time I go in, they're never caught up in the chart. Allergies. Are patients the best source of allergies? Don't expect that to just magically appear in the chart either. We have to ask them their pain level, what their concerns are. Do they have cultural preferences? This is especially relevant when it comes to putting in a dietary order. There are a lot of cultures and ethnicities and religious groups that have very specific dietary concerns, like not eating pork or they need to be kosher or something. So these are all things that you get just from talking to your patient. This is subjective data. This is what the patient tells you. It guides what you're doing, and it's important. So y'all have already started practicing therapeutic communication. We've talked about communication. This is just adding to it. It's an important part of your assessment. Now, inspection. We talked a little bit about that. This is what you see with your eyes. Anything you can see with the naked eye, or you can even use assistive equipment. So assistive equipment's like your pen light when you're checking pupils, or an otoscope, or an ophthalmoscope, or whichever, which we don't go quite as in-depth on as entry-level LPNs, but depending on where you end up practicing, these could be very relevant. You're looking for skin color. Is someone sweating? You can tell that by looking. Is there swelling? You can tell that by looking. Are they symmetrical? Is one side higher up than the other, or is their chest, one side's inhaling while the other's not? How's their posture and gait? How are they moving? What facial expressions are they making? How much of our communication is nonverbal and we can tell by what their faces are doing? Do they have rashes? Do they have wounds? Do they have drainage? Do they have tubes attached to them? You're going to see those before you feel them, and I hope you don't smell them, but you're taking all this information in. Now, this is objective data. That means that what you observe, someone else, including Mr. Forney, could walk in behind you and see the same thing and write down the same observation. This can often be one of the first clues that something's wrong. Now, little clinical tip. I like this tip. This happens the moment you walk into the room. This happens every time you're talking to anyone. You just don't even pay attention to it. You can look and see Mr. Forney looks like he's happy today, or he looks like he's in a bad mood just when you walk into the room. Your classmate, are they smiling and cheerful, or are they disheveled and look like they've been crying or something? You're doing this assessment anyways. Now just give yourself credit for it and pay attention to what you're actually observing. That's more what's going on here. Palpation. Use your little baby hands. So this is using your hands to feel the external surface of the body. This, you can check the temperature, how warm somebody is, or how cold they are, how moist or dry they may be. Turgor, remember we checked turgor by pinching to see if they have a little tinting. That can tell us about dehydration. We can palpate those like lymph node masses and things. We can tell if something's tender by touching. When I touch, ow, it hurts when you touch me there. We palpate our pulses. We assess edema. You can't just look at edema. We're going to get more in depth on edema later in the term, but edema we judge by when we push, does it stay depressed or does it bounce back again? Even organ size, that gets into more advanced practice, like the deep palpation around the abdomen to feel livers and things. So I don't really want you guys doing deep palpation at this point yet, but know that that's something that's in medical practice. Now, cultural consideration, ask before touching. Hey, is it okay if I touch you? It's simple. Don't make it weird. It's only weird if you make it weird. Nurses are expected to touch, but know that you are entering someone else's space. And some cultures will have different ideas about that. I always like to say, hey, I just want to let you know, hey, can I touch that? Just no big deal. Don't make it a big deal and it won't be a big deal. But be sensitive. Percussion, I'm not going to dwell on percussion because again, we don't do a whole lot of it. But what it is, we're striking body parts with our fingertips. That helps make noise. We can hear if it's dull or if it's sharp, if it's kind of resonant or not, and that can help once you get a lot of practice under your belt. And again, this is more advanced practice. To tell if someone's full of water or full of fluid or full of air or something, if they're very gassy, that kind of thing, it can be helpful. But don't stress this. I just want y'all to know that it exists. Auscultation with your great big elephant ears. I like that. We're listening with our stethoscope primarily here. Now, there is some auscultation you can do just hearing across the room. I can hear some lung sounds, and like Strider, you'd hear across the room. I can hear if they're coughing. I can hear how they communicate. Are their words clear? Do they make sense? Are they feel like they're tripping over their tongue, or they're garbled, or their words don't make any sense? Whatever. I can hear a lot there, but I can also come in and use my stethoscope and listen to lung sounds, heart sounds, bowel sounds, artery sounds. And these different sounds can tell me if something's changing in the body. So those lung sounds, if I hear coarse or wet lung sounds, that can mean that someone's got a lot of fluid on their lungs, and they may look okay right now, but they may decompensate very quickly, actually. Our lungs are very important. So this auscultation can help you get ahead of an emergency before it gets too bad. And if you do have someone who rapidly changes, it can help you figure out what that problem is really soon. So the thing I tell everyone about auscultating is put your stethoscope on as many different people as you possibly can. You're building up your encyclopedia of what normal sounds like every single set of lungs you listen to. So keep doing that. That's your path forward. Don't be afraid to put the stethoscope on people. Olfaction. This is smelling with the little kitty cat nose. There are some specific things. So we can smell breath. We can smell wound drainage. We can smell if urine is extra stinky. That can indicate some things. We can smell stool. Some people can smell C. diff. I've never been able to smell C. diff. I've cared for plenty of people with C. diff. I've been around it. I just don't smell the difference between C. diff poop and normal poop. But there's a lot of information we can get from this. It's one that we don't normally think about as much until we really think about it. It's like if things smell normal, it doesn't even cross your mind. So I don't necessarily go out of my way to observe what things smell like, but if I note a different smell or an odd smell while I'm doing my normal duties, I'll take note of that, and that can be relevant. Things like those, the diabetic ketoacidosis, that DKA that's in the parentheses there, can very commonly produce a fruity kind of acetone smell as that comes out of their breath. And different conditions can have different smells, but start paying attention to that. Now, subjective versus objective, we have talked about this before. I'm just going to rehash it just a little bit. Subjective is what the patient tells you. That is things like pain level is always subjective. Nausea, if they say they're nauseous, that's subjective. Now, if they vomit, that's objective. Because anybody can go in and see vomit that just came out of your patient. Are they dizzy? Are they anxious? Those are subjective things. Are they fatigued, tired? I can't tell that by looking at you. I have to hear it from you. Whereas objective, this is what I've looked at, I've listened to, I've smelled, I've seen, I've done all the things that someone else could come back behind me and find the same information. All of this information is important, so don't underscore any of it. We like to be as objective as we can with these things, but we're dealing with people, and being a human in and of itself is a subjective experience. So don't be afraid of that kind of information. Now, the critical thinking element. Assessment is not a checklist. That is huge. Take in your whole patient. Your assessment's going to look different patient to patient. So the head-to-toe assessment that you learn in your skills lab is really nice when you have a patient who will move around with you and answer your questions and do what you expect them to do. And suddenly you have to change it all when you have a patient who can't move when you ask them to, or they're demented and can't follow your instructions. Is it still important to do an assessment? Yes, absolutely, you still have to do an assessment. But it's going to be different. Now, within that, are these findings normal? Are they abnormal, but they're normal for your patient? That's important to deduce. Or have they had a big change? This can be really hard, like if someone just comes into the emergency department, think an older person who might have some dementia anyways, and they show up and they're very confused, they're A&O times 1, they only know their name, and you don't know any different, maybe that's normal for them. But then their family member comes in and says, oh no, at home, no, she can't keep the time straight, but she knows everything else. This is very much more confused than her normal. Then we can say she's having an acute mental status change, which can point us in another direction. Now, does this finding make sense with what the patient has going on? Did they just come back from the OR and they have pain around their surgical site? That makes sense. It's an abnormal finding, but it totally makes sense in this setting. Versus, did they come back from the OR and now they have their abdomen is gently filling and getting fuller and their blood pressure is dropping? That's an abnormal finding that could indicate internal bleeding. Are there patterns or clusters of findings? Are you finding a lot of things wrong at once? So you did a lung assessment and you noticed their lungs sounded coarse, but you also see they're breathing funny and they're tired and lightheaded. Those could go together. Did one piece of assessment open me up to have to do more assessment? That can happen. Now, did I find something that's abnormal? Who needs to know about this next? Is this something I need to call the doctor right away? Or should I check with my charge nurse, run it by them? Or maybe it's a true emergency and I need to call a rapid response or a code blue and do something with it. Or it could be, you know, they're a little nauseous after their meal. They ask for Pepto-Bismol. You send a little text to the doctor and they say, okay, whatever. You got to figure out what the right answer is. And that comes with practice, but don't be afraid to ask your peers and colleagues. That's something I like about nursing. I'm always around other nurses I can run my ideas off of. So normal versus abnormal. To recognize abnormal, you must first know normal. So why do I keep telling you all to listen to as many different sets of lungs as you possibly can and touch as many different people as you can? So that you'll build this big encyclopedia of what normal looks and sounds and feels like, so that when something doesn't match that, you'll be able to say, hey, that's not normal. You may not be able to say exactly what it is, but if you can raise a red flag and get another nurse who's got more experience in there, or get the resident to come assess the patient or do something like that, you've done a pretty good job, honestly. But you only get there by learning what normal looks like. So practice this assessment. Then we also got to think about patient-specific factors. Age is different. So like babies breathe very different from grown-ups, and it was alarming when I brought my newborn home and her breathing was ridiculous, but that's just how newborns breathe. You know, older people have different things. They're different from younger people. People will have different conditions based on their medicine or diagnosis. Some things are expected. So anytime you're in doubt, run it by somebody else. Hopefully there's another more experienced nurse on the unit you can run these ideas by. If you have a preceptor or a charge nurse or something like that, don't be afraid to ask. Because the last thing I want is you to let your ego drive the ship and say, I know everything, and then find out the hard way that you don't. I don't know everything. I love running things by other people. That's the best way for me to learn and make sure my patients stay safe. And I expect you guys to do the same, and I think you all will do great. When to report and escalate. So immediate reporting needs to happen if you have significant changes in vital signs. That's talking, you know, maybe the facilities have standards for this, but it's usually a 30-point change on blood pressure is immediate rapid response. you know, a big percentage change in oxygen, you know, maybe 10% change in oxygenation, 30-point change in pulse that's not explained, that kind of thing. If we have a new onset of chest pain or difficulty breathing, those always need to be reported and escalated. I cannot tell from the subjective information of the patient talking about their chest pain whether they're having a heart attack or a panic attack, just from the words they tell me typically. If they have a change in their level of consciousness, if their consciousness goes down, maybe they were totally coherent at 8 o'clock when you did your initial assessment and now it's 12 o'clock and they're ranting about Judge Judy and Judge Judy hadn't been on for 3 hours. That would be a little alarming, right? They can't remember their name anymore. If you notice new signs of bleeding or shock or a sudden change in patient condition, any of that. Even if it's smaller changes than that, if you're not sure, run it by somebody else. The hospitals are really good, first of all, about having a lot of nurses near each other that we can run these things by, but also the hospitals I've worked at have had rounding nurses. Those are ICU nurses that their whole job is to round around the hospital and check on patients that you have questions about. They respond to rapid responses and code blues, so they do have things they'll get called away for, but they're also available for you to call anytime something's not measuring up to what you expect. They're usually super friendly, approachable people in my experience, and they can be a fantastic resource. So don't feel like this is all on you, and don't be afraid to ask as you go, especially while you're figuring out what normal is. Now, documentation, we are going to talk a little more about documentation in the next presentation, I believe, but everything you do has to be documented. So all your assessment findings, both normal and abnormal, you want to use objective, descriptive language, use medical language, and you're going to follow your facility protocol. So most of the hospitals, all the hospitals in the area that I've been at recently have all switched to Epic at this point. So it's usually charting in Epic. In Epic, we chart by exception. If we have a body system that is all within defined limits, which they have very clear descriptors of what within defined limits means, you just hit WDL and move on about your business. If you have things that are outside of normal, you have to find a place to chart it. I promise there's a place somewhere in there to chart anything you can think of. But that you got to find it. Sometimes you got to hunt. So depends on your facility. This will make more sense when we start doing clinicals, because I will have y'all charting pretty quickly in clinicals. And this shows that you did something. It's also a communication tool. It's how the other nurses and staff members can see what their patients are looking like and what's going on, and helps you see if your interventions made any difference, because you get to record it over time. So, bringing it all together, the assessment process. First step, before you go in, it's always good when you can to review the chart and see kind of the patient's baseline and get an idea what you're going in for. Then you'll introduce yourself to your patient. Hey, my name is Nurse Nick. I'm going to come do an assessment. I'm going to be your nurse today. Do you need anything while I get this together? Hand hygiene as soon as you go in the room. Interview patient while making your initial inspection. So this is where I like to start with a cognitive sort of thing, where I'm paying attention. Do they make sense? Do they look like they're put together? That sort of thing. Then the systematic physical examination, the head to toe piece. Once I have my findings, I'll compare them to baseline and normal values, and proceed from there. See how it goes. So all this connects to what we've been practicing in the skills lab. Don't let it overwhelm you. They're all building blocks. We got to build this, and the assessment that you do in skills lab is a little bit robotic, but you'll find that you get to shift it for every patient that you work with. So we kind of have to start small and we'll build on it. So don't worry, we're building up what normal looks like, and we're building up practice as we go. All right, assessment never stops. You are constantly assessing. Use all your senses. Critical thinking turns this into something we can actually act on. Your documentation and communication are as important as the assessment itself. That's a good way to put it. Part of your assessment is communication, and then when you document it, that's communication itself. When in doubt, ask somebody else. See what's going on. Let somebody else come put eyes on them. That's part of the deal. Your assessment skills will get better with time. Keep practicing and trust your instincts. Seriously, y'all may not have a lot of intuition yet, but that comes with practice. If something doesn't seem right, even if you can't put your finger on it, bring attention to it. If that's my mother, I want you to get extra eyes on her, even if she's just fine and maybe she's a little gassy or something. I'd rather you bring another nurse in and, oh no, it's no big deal, versus my mother gets hurt. So anyways, this concludes this lecture. I've got 3 more coming your way shortly. If this is for my CPCC class, don't hesitate to reach out on the discussion forum online with any questions that you have through this. Stay safe.